Hello, everybody. Today I'm going to be talking to you about how to assess aortic stenosis. I have no conflicts of interest to disclose. I urge you to review this ASE guidelines document, which is the recommendations on echocardiographic assessment of aortic stenosis, and this is a focused update that was published in 2017. It has lots and lots of good material, and much of what I put together in this talk actually comes from this particular document. So let's first talk about the epidemiology of aortic stenosis. We know that 1 out of every 4 patients who are older than the age of 65 have aortic sclerosis. 1 out of every 6 patients with aortic sclerosis advance to aortic stenosis within 7 years. 4% of Northern American population older than 75 have aortic stenosis, and about 50% of patients with mild to moderate aortic stenosis progress to hemodynamically severe aortic stenosis. So it's important for us to keep in mind because it is a very common problem. We're all very much aware of the natural history of aortic stenosis in this graph that was published by Ross and Braunwald back in 1968. And even though this particular graph was created with a very small number of patients, it turns out that it is quite true and still holds today. And what we know is that individuals with aortic stenosis, even when it's severe, may have a latent period when they feel perfectly fine. And over that time, there is increasing obstruction and myocardial overload that the body can compensate for until a certain time. And then when the onset of symptoms happen, and most commonly those include heart failure, syncope, and angina, the survival drops off precipitously. And so we have to watch out very carefully for these onset of symptoms because that's usually the trigger that some type of intervention on the valve is necessary. And we know that if we do intervene, in this case it's operated, but now we can include TAVR in that group as well, we know that the survival can then return back to the normal pre-symptomatic state. And we do have several predictors by echocardiography, mainly that being of a peak jet velocity greater than 4 meters per second. And according to Dr. Otto's publications, only 21% of patients with a jet velocity over 4 meters per second were alive and free of aortic valve replacement after 2 years. So the echo as well as the clinical assessment are very important when we're following patients with aortic stenosis. So there's several steps that we have to keep in mind when we're treating patients with aortic stenosis. Of course, there is the echocardiogram, which we're going to be focused on today, but we have to combine the echo with our clinical assessment and then put it all together to figure out the treatment options. And now we have more options with the advent of TAVR, whereas before surgery was our only option. So there are some common etiologies for us to be aware of. First, there is degenerative aortic stenosis, and that's quite common, particularly in the developed world. And here's an example of a patient with senile or degenerative aortic stenosis. And then there's the bicuspid etiology, which is actually quite common as well. And here's an example of that. And then in the third world, probably one of the most common is rheumatic. And you see here that the rheumatic valve is mostly affected at the tips of the leaflets, which you could also see in this photograph of the pathologic study as well as on the cartoons. So it's important for us to identify the etiology of the stenosis because it may impact our treatment. So being able to recognize those different etiologies is important from the echocardiographic standpoint. And we can't forget the aorta. Many times patients with aortic stenosis also have associated enlargement of the aorta, so we have to carefully evaluate that structure as well. So the echo exam also needs to include visualization of the aorta at the sinuses of Valsalva, sinotubular junction, and the ascending aorta, and measurements need to be done in all those locations at end diastole. And here's an example of such a measurement. And oftentimes it's necessary to move the ultrasound probe up an intercostal space so that you could actually visualize the true ascending aorta. And in this example here, this is a parasternal long axis view with the probe at a more inferior location, and you see that the aorta measures 4.5 centimeters. However, moving up an intercostal space, we find that this individual actually has a very large ascending aortic aneurysm. So don't forget to move up an intercostal space when evaluating the aorta. In order to quantify aortic stenosis, we want to obtain a blood pressure, the measurement of the LVOT, CW of the aortic valve in multiple views, PW of the LVOT, and oftentimes I also like to confirm the stroke volume measured at the LVOT by also calculating the stroke volume of using the left ventricle. Hemodynamics that you need to report on your echo summary include the peak velocity of the aortic valve, the peak and mean aortic valve gradients, the aortic valve area, the velocity ratio, or otherwise known as the dimensionless index, and the stroke volume. Now, measurement of the LVOT diameter can be quite tricky. The main thing is that it is done from the parasternal long axis view in the zoom mode, and we want to measure from inner edge to inner edge of the septal endocardium and the anterior mitral leaflet in mid-systole. Where there's some disagreement is exactly where that measurement should be made. Some measure at the annulus, and others measure 0.3 to 1 centimeters below the valve orifice. If the LVOT is tubular, as it is in this example, no matter where you put the measurements, in this case, the measurements are going to come out looking very, very similar. But keep in mind, there is some controversy, and whoa, my computer just went nuts here.
I can pause it.
Yeah, pause it, because measurement of the LVOT can be very tricky. It is done from the parasternal long axis view in the zoom mode, and it's important to measure from inner edge to inner edge of the septal endocardium and the anterior mitral leaflet in mid-systole. That, no, there's no disagreement for. What there is some little bit of disagreement is exactly where in the LVOT the measurement should be made. Some measure at the annulus, as shown with this arrow here, and some measure 0.3 to 1 centimeter below the valve, where your PW sample volume would normally be. There's no incorrect way to do it regarding the location. It may depend upon the anatomy of the LVOT. In this example here, the LVOT is very tubular in shape, so all three of these arrows are actually giving you the exact same measurement. So in this case, it may not matter. Where it does matter is if there's extensive calcification around the annulus of the valve that may limit where you place the measurement cursors, or if you have a very sigmoid septum that kind of bulges into the LVOT. In that case, maybe a more annular measurement may make more sense. So you may have to tailor it according to the patient, but just understand that there is a little bit of controversy there. But the main thing you need to know is really this information here. So what are some of the pitfalls of measurement of the LVOT? One is that it assumes a circular orifice, and we know that in patients, including those with bicuspid valves, that the LVOT may be more oval in shape as opposed to circular. As I've already mentioned, there's a lack of consensus for the exact location of the diameter measurement. And as I've already stated, this measurement can be difficult in the presence of aortic annular calcification or a sigmoid septum. Now, how about the peak velocity across the aortic valve using CW Doppler? We do that by identifying the window, showing the maximum velocity obtained, and then we enter that information into the report for follow-up exams. So most commonly, we do this from the apical 5-chamber view, as shown in this example, the apical 3-chamber view, and then using our non-imaging transducer. We must be parallel to flow through the valve, which is why it's important to make multiple measurements in multiple different views. And don't try to use angle correction to manipulate the ultrasound transducer or the patient, because that will not give you accurate readings. So again, we want to use both our 2D transducer and the dedicated CW transducer, which is our non-imaging transducer. And some people call it the PDOF transducer. We want to do it in multiple windows. These are the windows with the 2D transducer. These are the windows with our non-imaging transducer. I would also include the apex here. We want to adjust the gain and the scale to optimize our signal. We want to acquire the spectral Doppler images at a slower speed to show at least 3 complexes, and then at a faster speed to actually do the measurement. We want to average 3 or more beats when in sinus rhythm and 5 or more beats when the rhythm is irregular. So here's an example of a CW Doppler of a patient with aortic stenosis. Here's our speed showing the more than 3 complexes. So you have an idea of whether or not there's any beat-to-beat variability. And then we change our sweep speed so that we get a more dedicated image of that spectral signal for accurate measurement. So when we measure our spectral signal, we want to measure the maximum velocity at the dense velocity curve. And don't measure the feathering, because that will overestimate your gradient. And you want to trace the VTI from the outer edge of the dense signal curve as shown in the diagram here. And here's an example of why it's important to measure from multiple different views. So here's an example of a patient with aortic stenosis with our dual 2D transducer. We're getting a peak velocity in the 3-chamber view of 4.67 meters per second. However, using the dedicated CW Doppler probe, we see from the right sternal border that the peak velocity is actually up to 5.3 meters per second. So really important to use all your tools and to look at this from multiple different angles. From that peak velocity, we can then calculate the peak aortic valve gradient. The calculation of the peak transvalvular gradient is based on the modified Bernoulli equation, which is the change in pressure equals 4 times the velocity squared. And then the mean gradient is calculated by averaging the instantaneous gradients contained in that signal over the ejection period. Unfortunately, this is something that our ultrasound machine can calculate for us. Keep in mind that the simplified Bernoulli equation assumes that viscous losses and acceleration effects are negligible. So the full Bernoulli equation is actually much more extensive than the 4v squared that we see here, but most of the time the rest of the stuff that's included in that equation can be ignored, and that includes the proximal velocities. However, when your proximal velocity is elevated, mainly greater than 1.5 meters per second, or your transvalvular velocity is not that high, less than 3 meters per second, that proximal velocity cannot be excluded and needs to be incorporated into your equation of the calculation of the pressure gradient. So then the equation becomes 4 times V2 max minus V2, it becomes, I'm sorry, the maximal velocity squared across the valve, which is your CW, minus the PW LVOT velocity squared, and then that calculation multiplied by 4. And that's going to give you a very different reading than if you just do the 4v squared. And in this situation, you're unable to accurately measure the mean gradient, and so that cannot be used to assess severity in that particular situation. Sometimes ultrasound enhancing agents, or otherwise known as contrast, can be useful to enhance aortic stenosis jets when the acoustic signals are poor. However, you do need to adjust the gain settings or you're going to overestimate the Doppler signal. And it's also helpful to wait until the contrast concentration has reduced before you start getting your spectral Doppler signals. So get all your LV and RV assessment first, get the Doppler signals last, once the contrast concentration is reduced, and then you'll be less likely to get blooming and overestimation. And here's a nice example of a contrast-enhanced spectral signal that was appropriately acquired. We also want to pay very close attention to the shape of the CW signal. So in cases of mild obstruction of the aortic valve, the peak velocity of the CW signal is going to occur early in systole, and the shape of that velocity curve is going to be triangular, as shown in this example here. Whereas in an individual with severe aortic stenosis, that peak velocity is going to happen in mid-systole, and the velocity curve is going to be more rounded, as shown in this example. So keeping in mind those two different shapes can really help you clue in as to how severe the stenosis may be. Other shape changes that we have to keep in mind is a subvalvular obstruction, such as what is seen in hypertrophic cardiomyopathy. So here is a CW signal of the aortic valve, and you see this overlying late peaking jet that is due to the subvalvular obstruction related to the hypertrophic cardiomyopathy. Because both jets occur in systole and may often be aligned in the same place when using CW Doppler, it is not uncommon to see those two signals overlap. And so the shape of the signal can clue you in as to whether or not the signal is related to the aortic valve or related to the subvalvular obstruction. Sometimes it can also be difficult to differentiate the aortic stenosis jet from that of mitral regurgitation or tricuspid regurgitation if the MR or TR jets are very close to the septum and may overlap with your CW Doppler tracing. In those cases, it's important to look at the timing. So with mitral regurgitation, the duration of the jet is longer than with the aortic stenosis. And same thing with the tricuspid regurgitation. It's going to be longer than that of aortic stenosis. See, notice how the jet goes all the way up until the mitral valve signal starts. Whereas with aortic stenosis, you do have the isovolumic relaxation and the isovolumic contraction periods that are between the aortic valve signal and the mitral signal, and thus that ejection period is shorter. So if you're not sure if you're dealing with MR, TR, or AS, measure the duration of the signals and compare them to each other to help you differentiate. Keep in mind also that there may be differences between pressure gradient calculations by echo versus cardiac cath. The main thing to keep in mind is that the echo peak gradient represents the peak instantaneous pressure difference between the LV and the LA, whereas the cath represents the difference between the peak LV and the peak aortic pressure. So here's the peak to peak, here's the peak instantaneous. And the peak to peak does not happen at the same time, so it's sort of a untrue, unphysiologic measurement, even though that's what's commonly done in the cath lab. But that's why we can't measure it in echo, is because the two do not happen simultaneously. What we're doing is we're measuring the peak instantaneous or the maximal pressure gradient between the LV and the aorta. The peak to peak is usually less than the peak instantaneous. Now the mean gradients, on the other hand, should be relatively similar. There's also a phenomenon called pressure recovery that can be responsible for echo Doppler gradients that are substantially higher in valve areas that are substantially lower than those measured on cardiac cath. Let's move on then to the pulsed wave Doppler of the LVOT. So here we want to do our PW Doppler measurements in the apical 5 and the apical 3 chamber views. And we want to position the sample volume just on the LV side of the valve at the point where flow becomes laminar. So we don't want aliasing, we don't want to be in the valve, so if you see any aliasing, you have to inch back into the LV. And oftentimes also, we also want to see the closure clicks of the valve. Ideally, it should be in the same place as the LVOT diameter measurement. so that we're accurately calculating the area of the LVOT, although with the caveats that I gave to you earlier regarding some of the challenges associated with measuring the LVOT diameter. We want to set our scale. Okay, pause, please. Sorry. Let's talk about the acquisition of the PW Doppler signal of the LVOT. So this is something that we need to do in the apical and the 3-chamber views. We want to position our sample volume just on the LV side of the valve at the point where flow becomes laminar. So we don't want any aliasing. If you see aliasing, you need to inch back into the LV until the aliasing disappears. And we also want to see that valve closure click mark here. Ideally, we want it in the same place as the LVOT diameter measurement, although with the caveats of the challenges in measuring the LVOT diameter, as I mentioned to you earlier. We want to set the scale and the baseline to optimize the spectral display, and you want the wall filters, a low wall filter setting. We, similarly to the CW, we want to acquire at a lower sweep speed so that we have at least 3 complexes for visualization, and then at a faster sweep speed for measurement. We want a smooth velocity curve showing well-defined peak and a narrow velocity range. And we want to measure the maximum velocity from the peak of the dense velocity curve. But then we also want to trace the VTI from the modal velocity, which is actually in the middle of this outer edge here. So here, again, is an example showing you at least 3 complexes and then changing the sweep speed so that we optimize the ability for us to do our actual measurement. All of these values can be put together to then calculate the valve area. The calculation that we use for the valve area is the continuity equation, and that equation is shown in this slide here. And I strongly encourage you, if you have not done so already, to memorize this formula, because I strongly suspect that there will be several questions on the exam asking you to calculate the valve area. Now, the concept behind the continuity equation is the principle of conservation of flow, so that we know that flow on one side of the valve must equal the flow on the other side of the valve. When we're talking about the aortic valve, we're talking about flow in the LVOT versus flow in the aortic valve. To calculate the flow in the LVOT, we need the LVOT area, and then we need the VTI of the LVOT that we obtain with our PW sample volume. And then we're going to solve for the aortic valve area, and then we also need the VTI of the aortic valve using CW Doppler, and both of these together give us the flow on the aortic valve side. Since we're going to be moving our equation around to solve for the aortic valve area, we're going to move the VTI of the aortic valve over to the denominator over here to get our final continuity equation for the aortic valve area shown here. So the items that we need to do this, we need a PW, LVOT, VTI, we need the diameter of the LVOT to calculate the area, and we need the VTI of the aortic valve using CW Doppler. So here is how we calculate the area of the LVOT, and the calculation is pi r squared, and r being half of the diameter that we measure in the LVOT. And then if we do 3.14 times r squared, we actually get d squared times 0.785. So either of these are the 2 derivations of the same thing. You can use whatever calculation is easier for you to remember. And it's really, really important to try your best to measure the LVOT diameter correctly. Remember about the inner edge to the inner edge, and the indications that I gave you on that slide back when we discussed measurement of the LVOT diameter. And because it is a squared value, it can make a big difference in terms of the calculation of the valve area. So here I just show you an example of an LVOT diameter that was measured at 1.7 versus one at 2.1. because of the squared nature of this number, it's a difference between 2.27 and 3.46 centimeters squared for the aortic valve calculations. So doing a good measurement is really, really important. I also want to talk to you about the velocity ratio, or the dimensionless index, as I like to call it. And this removes the cross-sectional area of the LVOT from the continuity equation. And I find this index helpful, particularly when I'm not sure if I can trust the LVOT diameter and thus not trust the LVOT area. And basically then what we're left with is the VTI of the LVOT divided by the VTI of the aortic valve. And essentially this is the continuity equation just without the LVOT area. And a ratio less than 0.25 is considered to be severe. This is a chart from the aortic stenosis guidelines that tells you all the different criteria that I've mentioned to you and what's considered mild, moderate, and severe. And I do encourage you to memorize this so that both in your clinical practice and in your studying for your exam and passing the exam, you'll know how to differentiate mild, moderate, and severe aortic stenosis using the different criteria. So let's look at an example. So here's a patient with a very calcified aortic valve that does not seem to be opening properly. We measure our LVOT diameter at 2.1 centimeters. Then we get our LVOT VTI from looking at the PW sample volume in our LVOT, and here the VTI is 31 centimeters. We get the CW of the aortic valve, and I'm showing you here a VTI of 124 centimeters per second. The peak velocity is 4.6 meters per second. The peak gradient is 85 millimeters of mercury. Mean gradient is 53 millimeters of mercury. The dimensionless index is 0.25. The aortic valve area is 0.9. The stroke volume is normal at 54 mLs per meter squared. And if we look at our table of what's considered severe, all of these variables fall into the severe range. So this is clearly a patient with severe aortic stenosis. This is another more challenging patient who was in the ICU, very short of breath. You can see here that her image quality is very difficult. She does look like she has a very stenotic aortic valve, but we're only getting a peak velocity of 2.8 meters per second. Look at the shape of the jet, however. It does have that more rounded appearance as opposed to that triangular shape that I talked to you about. So we suspect that the aortic stenosis is probably more severe than what these numbers suggest. So a different sonographer went to try to acquire the images and reposition the patient, use some ultrasound enhancing agent or contrast agent, and now is able to achieve a peak velocity of 4.1 meters per second, which is more in line with the severe stenosis that was originally suspected. So again, pay attention to the shape, pay attention to what type of image quality you have to see if you believe the numbers or not. When the numbers don't make sense, make sure you double check your measurements. Assess heart function and look for structural heart disease. Remember that velocities and gradients are flow dependent. You need to carefully measure the stroke volume to assure accurate interpretation of aortic stenosis severity. There is an entity called low flow, low gradient aortic stenosis that really drives home this point. That is the topic in another lecture, so I'm not going to spend too much time here, but I just do want you to keep in mind that velocities and gradients are flow dependent, and if the flow or the stroke volume is high, your velocities and gradients are going to be high. If the flow is low, your velocities and gradients are going to be low, and you need to make sure you take that into consideration when you're determining the severity of the stenosis. So there are several items that I think that you should know for the board examination. One, know how to measure aortic valve velocities and pressure gradients. know the pitfalls, know exactly how you're supposed to do it, know how to make the basic calculations for pressure gradients and for the aortic valve area, know how to interpret the velocities and the pressure gradients even when the values are discrepant, understand the pitfalls of each measurement, recognize the different patterns of aortic stenosis spectral Doppler profiles, and from the Doppler profiles you should get an idea if something is mild or severe, and appreciate the relationship between velocities and gradients and flow, and incorporate stroke volume into the interpretation of aortic stenosis severity, which again, you're going to hear more about in subsequent lectures. With that, I thank you for your attention and I wish you the best of luck on your examination. Thank you.